I think now's as good a time as any to start. So I'd like to welcome everyone today to our second patient and occupational safety webinar. We're very excited to be here. Following on from our successful first webinar, we're pleased to be here today to look at a topic that's been on everybody's minds over the last 18 months, that of PPE. Now today, we're not going to be talking about PPE and COVID. We're going to be discussing personal protective equipment in relation to us as a cancer nursing community who care for patients receiving hazardous drugs. And the reason we're here today is due to a very important piece of work that we undertook into patient and occupational safety within our advocacy working group in EONS. We identified in a survey that only 1 in 6 cancer nurses had access to a full gown with arm coverings when administering chemotherapy. Equally, some of our cancer nursing colleagues across Europe are not only responsible for administering chemotherapy, they're equally responsible for preparing chemotherapy as well. My good friend and fellow advocacy working group member, Helena Ullgren, and myself will be chairing this webinar today. And we're very pleased to announce that we have some exceptional speakers with us today. We're very lucky to have Dr. Miriam Krul, who is a senior oncology pharmacist in Amsterdam. She's also on the board of the European Society of Oncology Pharmacy, as well as the European Cancer Organization. Following on from Dr. Krul, we are equally fortunate to have 2 good friends of mine who are 2 senior colleagues in the United Kingdom. Alison Simons is a senior lecturer and pathway leader for cancer and hemato-oncology at Birmingham City University, and her colleague Sam Toland, who also works as a lead chemotherapy nurse practitioner. All of our speakers today have a wealth of experience in chemotherapy safety, and we look forward to hearing what they have to say today. We will also have 2 cancer nursing colleagues who have prepared some short videos about their experiences of PPE in cancer care. We have Maria Diaz from Portugal and Harold Titzer from Austria. As anyone who knows us at EONS, we are fond of a good debate, and there will be the opportunity to ask all our experts at the end of the webinar some questions. Whilst the event is live and our speakers are with us today, please be aware that our speakers pre-recorded their sessions as we navigate our way through these challenging times. Helena and I lend you all a warm welcome today, as well as our speakers. So without further ado, hello Miriam, Alison and Sam. We would equally like to welcome you all today and thank you for taking time out of your busy lives to be with us. The presentations are translated into many languages, hence I advise you all to go into your respective breakout rooms when we start. If you have any problems accessing any of the recordings, then please just let us know in the chat and we'll make sure that we remedy this for you. Following the recordings, we will invite you all back into the main room for questions and answers time, so please think up some questions for our panel. Please remember that if you have colleagues that can't attend today, that all videos will be uploaded to YouTube as well. One final point, your microphones will be muted at all times during the presentations. And as I say, please think of your questions and answers for at the end as well. And I'd now like you to make your way to your respective breakout rooms.
Welcome to EONS Patient and Occupational Safety Webinar series. My name is Celia Díaz de los Ríos, and I am going to give a short introduction before we start with the theme for today's webinar. We are going to be doing 4 webinars in this 2021. They are all going to be based on the EONS Safety Manifesto. The webinars are developed by cancer nurses and for cancer nurses, with the aim to raise awareness and increase knowledge. We have different world-leading experts as speakers, each of whom are going to be looking at the evidence and the clinical implications of each of these 4 important topics. All of these webinars, as many of you will be seeing today, will be translated into different languages to try to make it accessible to all. If you attend the 4 webinars, you will receive a certificate. And also, if you are interested in the credits, there will be the chance of doing an online test so you could ask your university for ECTS credits. We are very proud to have managed to do this webinar without sponsorship from industry partners. It is a very important topic where we don't want to be looking at any particular brand. We want to look at everything and how it should be done. The webinars are going to be accessible for 6 months after the event. So now, looking into the why of these webinars. Unfortunately, we still need to work a lot to improve patient safety. Healthcare has become more effective, but also more complex. In all healthcare, but especially in oncology, there are new technologies, medicines, and treatments coming every year. Our patients are getting older, and we are able to treat sicker patients with significant comorbidities. But this means that they have higher risk of experiencing medical errors. Of hospitalized patients, 1 in 10 will experience a medical error. Most of them could have been prevented. Unsafe handling of medication are very frequently reported. And we, nurses, the largest group in healthcare, we are in contact with our patients 24 hours, 7 days a week. So we are in a unique position to prevent those errors. If we look at cancer patients specifically, they are particularly vulnerable to harmful events. While we were talking about 1 in 10 hospitalized patients experience medical errors, 3 in 10 patients in oncology experience harm. Patients are exposed to complex and advanced treatment options with highly potent drugs with narrow therapeutic index. With cytotoxic agents that are the most frequent drug involved in medical errors, and a larger number of new drugs and oral therapies. And for them, errors may have catastrophic consequences. Occupational safety is very important, but unfortunately, often overlooked. There is clear evidence of the health effect from occupational exposure to hazard and neoplastic drugs. PPEs reduce, but do not always eliminate risks. Most European countries do not protect their cancers from occupational exposure to the hazard drugs during pregnancy and breastfeeding. And even there are guidelines and recommendations, they are not always followed. Therefore, cancer nurses need formal education and training to minimize the risk for both patients, their families, and themselves. The EONS Safety Manifesto consists on 4 very important recommendations for cancer nurses. This series of webinars are based upon these recommendations, with one webinar focusing on each recommendation. The first recommendation is about pregnancy and breastfeeding. If you are planning to become pregnant or are pregnant or breastfeeding, tell your manager directly. Ask for alternative duties if you work with cytotoxic drugs, radioactive agents, or with open radiation sources. The second recommendation is on PPE. Nurses working with hazard cancer drugs should always use personal protective equipment in order to protect against the occupational risk of skin rashes, effects on reproduction, and even cancer. The third recommendation is about speaking up. Cancer nurses' actions are of great importance for safety. Safe procedures and the correct use of devices are crucial steps in safety promotion, as is the courage to speak up. The courage to question when adverse events occur in practice, including risk and including the near misses. The next recommendation concerns communication with and involvement of patients and their loved ones. As cancer nurse, you can always involve patients and their significant others by encouraging them to ask questions, to tell you directly if something is or seems to be wrong regarding any aspects of their care or of their treatment. This will reduce their medical errors and the risk of occurring. In this way, cancer nurses can contribute strongly to achieving high patient safety culture, will reduce the risk for both patients and staff. Here is some concerning data on safety from the EONS Cancer Nursing Index 2020. You can read more at EONS website. On the Cancer Nursing Index, they looked at different countries to see what safety concerns they have. Some of the results were that 45% of the countries provide no formal education before nurses handling cytotoxic drugs. Some countries have no written guidelines for nurses handling cytotoxic drugs. A big percentage do not have specific guidelines for occupational exposure during pregnancy or breastfeeding. And even worse, some nurses risk negative consequences if asking for alternative duties during pregnancy or breastfeeding to avoid occupational exposure. This should never happen. In 32 countries, systematic swab testing for occupational exposure are not performed, and in another form, only rarely and only in some workplaces. Then there are 22 countries that speaking up whistleblower systems are not implemented. And again, in another 5 are only in some places. In 14 countries, nurses report not always having access to cytotoxic spillage kits and PPE. In 6 countries, clinical nurses regularly prepare cytotoxic drugs. And in another 11, this occurs sometimes. Fortunately, in other countries, these risky tasks are performed by pharmacists in controlled and adapted environments, like pharmacy labs. So this is the reason to be here today, to change this.
Good day and welcome to all participants. In the next 20 minutes, I would like to take you through the latest studies on personal protective equipment and safe handling procedures for anti-cancer drugs. My name is Mirjam Krul and I work as a hospital pharmacist in Amsterdam in the Netherlands. I also hold a seat in the board of the European Cancer Organization and in the European Society of Oncology Pharmacy. My main daily task is to oversee the compounding department in my pharmacy and where we prepare all drugs, amongst others, chemotherapy. During this webinar, I will speak about hazardous drugs, and I consider that to be the drugs that can be carcinogenic, mutagenic, or reprotoxic, abbreviated as CMR. Of course, there are also other hazardous drugs, for example, radioactively labeled substances we use in diagnostics, but I will focus on CMR drugs and on the protective measures for workers in hospitals. On this slide, you can see the classification that is used worldwide for these substances with hazard statements that accompany the classes. Now, before we get into the scientific research on personal protective equipment that I will call PPE, I will briefly show you the current European directives on this subject and also a short overview of equipment that is available. After that, I will outline the most recent studies that have been done. European directives are the highest level of legally binding rules in the European Union. Each country has national laws, but these national laws have to adhere to the framework that is described in the European directives. National laws are allowed to be stricter, but are not allowed to be less strict than the European guidelines. In Europe, there is the so-called CM directive, and that describes how all member states and all employers have to protect their workers. Unfortunately, this directive is rather old, and it does not include licensed drug products. The directive dealing with reprotoxic substances is even older, and although it says that work may never harm a pregnant employee or the unborn child, also here, the handling of drugs is not described. Thus, the European directives, although they point us in global directions, do not give us detailed rules for the work that we do on a daily basis in oncology care. We use PPE to prevent exposure, and exposure can occur through 4 distinct routes that are depicted on this slide. Ingestion is easily preventable by not eating while you are performing hazardous tasks. Injection is partially preventable by avoiding the use of needles whenever possible. This leaves inhalation, which can occur, for example, when decanting urine, and dermal exposure, which can occur when contaminated surfaces are touched with bare hands. Dermal exposure can lead to internal exposure because you can transfer traces of cytotoxics, for example, when you eat after work, if there are still traces left on your hands. And in addition, several anti-cancer drugs can also penetrate your skin. Now, currently available PPE protect against exposure if they are used correctly and if they are of a proper quality. When looking at gowns or sleeves, it is very important that they have good cuffs so that there is no bare skin on the underarms. When looking at respiratory protection, please note that simple surgical masks are good when you want to protect the patient from microbiological risks, since everybody has some bacteria in the oral cavity and breathing them out is reduced by a surgical mask. Aerosols with hazardous drugs, however, can still be inhaled when wearing a surgical mask. So for really high tasks, such as cleaning a biological safety cabinet where the chemotherapy was compounded, P2 or P3 masks that you see on the slides are advisable. Now for gloves, there are international standards to qualify them and accompanying test protocols. Overall, gloves should be resistant to a panel of drugs for at least 30 minutes. The tests are done, as you can see on this slide, by a standardized test procedure. When the manufacturer claims that his gloves comply with one of the standards that you can see on this slide, there should be test data available for you, either on the internet or in the secondary packaging on the gloves in a leaflet, or if you request that from the manufacturer. Well, now I would like to show you the latest scientific studies that have been done. The first is called MASHA-1, and it included 16 hospitals in 11 countries. All hospitals took wipe samples of predefined standardized surfaces in the pharmacy and on the ward. After that, there was a training for the hospital staff and a standardized cleaning protocol was implemented. And then the same surfaces were wiped again, and this was repeated a third time a year later to see if any of the effects were not short-lived. On this slide, you can see the standardized cleaning protocol, which consists of a daily and a more extensive weekly cleaning. And here you can see the main outcomes. On the left, the wipes from the pharmacy, and on the right, the wipes from the ward. The pink bars show the percentage of contaminated samples in the baseline measurement, so before anything was done. As you can see, the floor under the infusion stand is the most contaminated spot. More than 40% of the hospitals that participated had contamination there. After the training and the cleaning protocol implementation, the contamination went down. Those are the green bars. And now this shows that unfortunately, there is a lot of contamination of surfaces in hospitals. Even after this intervention, there was still contamination. And we wanted to see if there were any good practices that hospitals with a relatively low contamination were using when compared to the hospitals that had a relatively high contamination. So we tested a lot of variables describing hospital practices and materials. First of all, some companies promote the use of closed system transfer devices. Those are not to be confused with spikes. You can see those spikes on the left of the picture. Spikes are very small and simple devices, and they have an air filter in them that prevents aerosols from leaving the vial. Closed system transfer devices, also abbreviated as CSTDs, are large and far more expensive, and they claim to fully eliminate the possibility of contamination. But as you can see in the graph in this study, the hospitals that used the CSTDs had in fact more contamination than the hospitals that used spikes. So the claim of being completely closed is not sustained by this study. But then what measures do lower contamination? Most importantly, the use of needle-free administration sets lowers contamination. And here you see two pictures. The left is what you should not do. Attaching a spike or a needle line directly into the bag with chemotherapy. And this colleague has also forgotten to wear gloves. What should be done is that your pharmacy dispenses the IV chemo with a side line that is attached to it and that is filled with sodium chloride or dextrose, so a neutral fluid. You can then attach that side line to the infusion system. That is a multi-way infusion system, so without using needles. And after that, you open the line. That way, if there is a spill, it will only be a spill of saline or dextrose, and you cannot be exposed to the chemo itself. The second study is a Dutch trial into dermal exposure. Hand-rinse samples were taken of nurses, pharmacy technicians, and cleaners after they performed their tasks. The results were compared with a limit value of 0.74 micrograms per week. Below this value, there is no evidence for reprotoxicity. And the people in the Netherlands are wearing PPE, like you can see on the photo in this slide. The results are given here, and are compared to a similar study that was done 10 years earlier. And in general, in those 10 years, the PPE and the safe handling procedures in the Netherlands became more strict. You saw that photo on the previous slide. It's one of my colleagues in my own pharmacy. The contamination on the hands of nurses decreased by tenfold. And one very important thing that I want to show is that decanting of urine in the second phase was no longer done. The conclusions from this study are that when the PPE are used, the exposure is low. There was one exception. Pharmacy technician who touched vials with bare hands had a high exposure. So we have given a lot of attention to that finding, and now the national guideline says that gloves should be used. You can see that on the photo on the left. We use gloves when we are unpacking the chemo vials from the secondary packaging. Also, our national guideline says that specific washing machines have to be used for urine bowls. These machines reverse and empty the bowl only after the lid is closed. So any aerosol from contaminated urine is not spread in the surrounding area. A very small but interesting study comes from Germany. Here, all staff from one ward were asked to collect their urine during a full work week. All urine was clean of cyclophosphamide and 5-FU, but it did contain very small amounts of platinum. Now, this does not mean, however, that cisplatin or carboplatin were actually ingested, because platinum is a naturally occurring compound. It is around in nature, but also in the exhaust of motor vehicles. So we use a cutoff value for platinum. All the nurses' urine fell below that. And importantly, the nurses reported wearing gloves a lot, 100% when administering chemo. This led the investigators of this study to conclude that wearing gloves is really important. Now, the last study I wanted to show you is Manifesto, which looked in a larger panel of hospitals, 28 hospitals from 16 countries. And 4 distinct locations in the oncology wards were wiped and checked for contamination. And also urine from workers was collected. The results you can see here, and it was shown that the floor in the nurses' room was very often contaminated. We also did a training intervention in this study, and this did lower contamination. The green bars are after training, but it did not fully eliminate it. From 32 workers, we got urine samples, and 3 were positive for cytotoxic drugs. And this means that these workers are not only exposed on the skin, but that the exposure also reaches the circulation. The 3 workers were all nurses. Again, we checked if we could see for good or bad practices. And again, we found that those multi-way infusion sets without needles, they have a positive effect. Also, the hospitals that had written standardized work protocols scored better. And the hospitals that do not crush tablets did better. Crushing chemo tablets will release powder particles and they can be spread or inhaled. So a safe way is to use a syringe where the tablet is allowed to dissolve inside it. If you have a patient that has difficulty swallowing or has an enterocrine tube, you can use this method. Well, in conclusion, I would like to highlight the most important point first. Every worker has a right to safe working conditions. Exposure to drugs that may cause cancer or may adversely affect pregnancy should be minimized as much as possible for every worker at all times. Thus, we need to update this EU legislation because this will force the individual national authorities to pay more attention to this subject. PPE are a right and should be of good quality. Therefore, there is still more research needed in this field. But until then, do not wait to ask your hospital management to provide you with good PPE that were proven to be effective in independent studies. You are entitled to it. Thank you.
Hello, thank you for the invitation and opportunity to speak to you today on the use of personal protective equipment for handling chemotherapy drugs, the nurse's perspective. My name is Alison Simons and I'm from the United Kingdom. I'm a cancer nurse by background and I'm a senior lecturer at Birmingham City University, where I lead the cancer and chemotherapy courses for qualified healthcare practitioners. You can see where Birmingham is on the map, pretty much in the middle of England. I'm here today with my colleague Samantha Toland, who is the lead chemotherapy nurse at a hospital in the UK and a senior lecturer at Birmingham City University leading the Hemato-Oncology and chemotherapy courses. We will be talking about the use of personal protective equipment, PPE, in the administration and handling of chemotherapy drugs from a nurse and UK perspective. We will be using the term chemotherapy drugs to encompass hazardous drugs, cytotoxic drugs, anti-cancer drugs, etc. I will start by discussing the guidelines, directives and recommendations that are available for nurses within the UK and identify the hierarchy of controls. I will then critique the PPE that is available for UK nurses in comparison to PPE for UK pharmacists and pharmacy technicians. Sam will then explore the presence of environmental contamination and how contamination areas are cleaned. She will then demonstrate the UK nurses' lack of awareness of risk and non-compliance to protective measures and over-reliance on PPE. It has been well documented that chemotherapy drugs are classed as hazardous drugs and as such can be hazardous to health due to accidental occupational exposure. We've known this for several decades and there are now numerous recommendations, policies, guidelines and directives in place to protect workers. As previously mentioned, the European directives are available and applicable to those member states of the European Union. Unfortunately, in my opinion, the UK is no longer a member state due to, yes, I'm going to say the dreaded word, Brexit. So those directives are not recognised or enforced within the UK. However, we do have the Health and Safety Executive, HSE, that includes a set of recommendations for practice in handling chemotherapy drugs. However, they are recommendations, so are not enforceable, and this results in the recommendations not always being observed in practice. There is also a yellow cover document for guidance of injectable cytotoxic drugs in clinical areas in NHS hospitals within the UK. But this is purely a guideline and is sadly not nationally recognised or adhered to. So this is the hierarchy of protection measures, which is stated within many of these documents. As you can clearly see, PPE is the third and final recommendation within the hierarchy. This means PPE should be used after all the other measures stated are in place and where adequate control cannot be achieved by other measures alone. Sam will refer to this hierarchy again later within our presentation. So let's look at PPE in more detail. As previously mentioned, PPE is designed to prevent or certainly minimise exposure to chemotherapy drugs. So is PPE different for different healthcare professional groups? You would be forgiven to think that it would be the same for all. However, in the UK, it's very different depending on your professional role. Let me show you. On the left, you can see that within pharmacy, there is full arm coverage to protect from splashes and absorption contamination. And in addition, there is respiratory protection to prevent from inhalation contamination. And rightly so. Pharmacists and pharmacy technicians are working with highly concentrated chemotherapy drugs and reconstituting and manipulating them, so they have to be well protected. So what do UK nurses administering handling chemotherapy wear? On the right, you can see they wear aprons and gloves. Yes, that is all. No gown with cuffs, no arm coverage at all. Nurses are working in direct conflict between safe protection from absorption contamination and infection control measures, which requires the nurse to be bare below the elbows. You can clearly see that there is a large area of skin exposed from the elbow to the wrist, which is at risk from splashes and aerosol particles. And nurses do not wear masks in any shape or form, unless during a COVID pandemic. So there is no protection from inhalation. The aprons are often very thin and come in only one size that does not fit all. They often tear very easily at the neck or at the tie-back sections. But nurses do wear gloves though. We've already heard about how important gloves are when handling chemotherapy drugs, and the international standards that gloves need to comply with. Therefore, the high quality of these gloves are imperative in protecting nurses from exposure. Again, within the UK, the gloves can be very thin and can rip very easily. Often the gloves are very short and only just sit on the wrist rather than extending some way up the forearm. When removing gloves, as nurses are bare below the elbow, there is also a risk that they may contaminate their skin, particularly if they remove their gloves by pulling at the wrist of the glove. Therefore, we need to consider compliance with gloves. Hospitals need to be aware of the safety standards gloves need to meet and how to ensure these safety standards are being met when purchasing equipment. Often, procurement may change suppliers for the whole hospital to save on costs, but without consulting chemotherapy units in terms of their specific requirements. It is therefore crucial that chemotherapy nurses know about these safety standards and how to check that their equipment meets these. I will now hand over to Sam to talk about the other points of contamination risks.
Thank you, Alison. As you will have discovered from the previous presentation, not only is there a direct risk to nurses during the administration of chemotherapy, there is also evidence that contamination exists within the environment, on surfaces within preparation areas, on floors surrounding treatment chairs, around drip stands, and even on telephones. Bearing this in mind, think about the importance of safety measures in all of the areas identified on the slide. Do you think you are adequately protected and/or carrying out correct procedures at all times? If you are wearing PPE, do you always wash your hands on removal of gloves and ensure nobody is eating or drinking in treatment areas? Do you always change your PPE when moving between patients or areas? There is also evidence to show that there is contamination on the outside of chemotherapy bags and syringes, which again emphasises the importance of being protected with PPE at all times when handling chemotherapy drugs, even when touching outer bags or syringes. However, as Alison has described, it is not necessarily all about use of PPE. It is also about how PPE is used and the safe practice procedures that should accompany this, along with an understanding of the risk of exposure in all areas where chemotherapy is given and where patient waste is handled too. And what about cleaning in these areas? In the UK, we do not have specific protocols relating to cleaning of chemotherapy administration areas, nor do we routinely obtain wipe samples to check for contamination. This may potentially put our nurses at risk of exposure as we do not monitor chemotherapy contamination, and many hospitals clean their chemotherapy administration areas in exactly the same way as any other clinical area. What we had observed in the UK was that often nurses are not completely aware of the risks associated with handling chemotherapy drugs, which meant that they may not always be taking adequate protective measures, both in terms of PPE use and other safe practice measures. We therefore decided to undertake a small-scale survey to investigate what nurses' understanding of the risks were, along with what training they had and what safety precautions were in place in their hospitals. We devised a short anonymous survey made of 8 questions, which we then shared on social media platforms, and then we analysed the results. We had 61 respondents to the survey, which found that many nurses did not fully understand the risk of exposure to chemotherapy drugs, specifically the mutagenicity, carcinogenicity, and reprotoxicity of the drugs. Only 2% of respondents identified this. They did understand that there was a risk, but generally they did not identify why. We also found that many of the nurses in the survey had not had any specific training or updates in the last 12 months. And it's within our HSE guidance, our Health and Safety Executive guidance, that anyone working with chemotherapy drugs should receive annual updates on the safe handling and management of these drugs. The survey also demonstrated that nurses relied heavily on PPE as their main control measure, and there was less attention paid to other measures, such as the use of closed systems for administration of chemotherapy, which was identified by only 20% of the respondents. In the UK, we cannot often use completely closed systems for administration, and this is because our chemotherapy drugs are mainly manufactured in large compounding units that are external from the hospital, and the majority of drugs therefore have to be transported from these units to the hospitals. Only a small percentage of chemotherapy is manufactured within the hospitals themselves. This means there is very little control over the production of chemotherapy from a hospital perspective. So any devices or adjuncts that could be added onto infusion bags or syringes to enable a closed system to be used for administration cannot be added by the manufacturing units. And this means in the majority of cases, nurses still have to spike infusion bags or remove caps from syringes of open chemotherapy, increasing their risk of exposure, which again emphasises appropriate and adequate use of PPE even more. I'd like to finish this presentation by going back to the hierarchy of control measures that Alison referred to earlier. As you can see, the recommended primary form of control is to use closed systems where possible, which is generally not possible for many nurses administering chemotherapy in the UK. Second to this is the control of exposure at source, i.e. adequate extraction systems and ventilation, use of safe practice measures such as training and education, and cleaning protocols. Finally, the third measure is use of PPE, where other measures alone cannot control exposure, which should be adequate to reduce the risk of exposure to as low as reasonably achievable. As we've hopefully demonstrated throughout this presentation, certainly within the UK, we have not yet achieved adequate control by using any of these measures to their full capacity. nurses are being put at risk of exposure by all activities of handling chemotherapy drugs on a daily basis. We are aiming to raise awareness of this issue in the hope that one day nurses will get the protection they need and deserve. Thank you.
Thank you. That was really, really interesting, specifically hearing it from a pharmacist perspective as well as a nurse's perspective as well. Yeah, very, I've always thought this, pharmacist, you've got this right. And I think we've got a lot of lessons to learn from our pharmacy colleagues. I'd like to hand over to Helena now, as she's going to be introducing some very short videos as well, if that's okay.
So I'm just going to let everyone come back to the main room, give it a minute or so. And I really want to say thank you to the excellent speakers. It left me inspired and a little bit provoked, and it was very interesting. So we're hoping to have an interesting Q&A. I think now most people should have come back to this main room, and I want to introduce two colleagues of ours that will give in short videos their perspective of PPE, examples from their countries, and they will be played all, you know, the first one and then the second one, and then we'll have the Q&A, and they won't be any subtitles, so we will all be here together. And the first nurse is Maria Diaz. She's a cancer nurse from Portuguese Oncology Institute, and she's also a PhD student in Barcelona University. And she will give her examples from her daily practice. And then we also have the manager perspective, which is very important for us to, you know, to get managers involved in those discussions as well. And this is our colleague Harald Titzer, that is a head nurse in an oncology clinic in Vienna, Austria.
Hello, I'm Maria. I'm a Portuguese nurse and I work in Portugal in the oncology hospital. So I'm here to talk our daily basis work and to answer some of your questions. So for start, yes, all of us, we have access to personal protective equipment. And we learn how to use it at the beginning when we start working at the hospital. For all the professionals, is like mandatory to work at the hospital. We have to do some training when we start to work there, and after that training, every year we have to do it again. So to remember and to update some things that are changing all the time. So we have to do it for some things like risk control. We have to do it every year, but all theoretical training we have to do it 2 in 2 years. It depends, but yes, we have to do it. And for nurses that work with chemotherapy, or we work in radiotherapy, we have a specific training to specific local work locals. So for chemotherapy, yes, we have a specific training to nurses who do it. And to talk something about the swab testing, the microbiology testing, the protocol says that we have to do it once a week at the laminar flow chamber, and for workplaces that are more clean, we have to do it once a month. So that is what the protocol says. So thank you for the opportunity to talk with you and say how we do it in Portugal at my hospital. I hope the answers are what you need, and bye-bye. Thank you.
Hi everyone. I'm very happy to send you the warmest greetings from Austria, and I'm happy to talk about this very important topic. Since 2011, the Agency of Safety and Healthcare in Austria published the so-called cytotoxic decree. The decree says that nurses are required to use personal protective equipment when administrating chemotherapy. We only deliver chemotherapy in the hospital setting, and every hospital operator has the responsibility to offer the equipment to everyone who is involved. As a nurse manager, it is my responsibility to offer nurses the training and the education they need. In every hospital where a cancer nurse starts to work, she or he gets a basic or fundamental training in how to use cytotoxic drugs and how to use personal protective equipment. And this includes basics in pharmacology, the personal protective equipment, safety products, and safe administration with a closed system, for example. There are some topics in how to deal with secretations, extravasation training, spillage training, and a small part of patient education. As I mentioned, every nurse gets a basic or fundamental training in the beginning of the work on an oncology unit. Every nurse needs to have a mandatory annual training, including an update about the newest cytotoxic drugs, spillage training, and training in extravasation. We perform irregular swipe tests in most of the clinics in Austria. More often, we do it in the Department of Pharmacy. I think the swipe tests in the past were really important, and to argue for spending money and resources in the equipment and the education of nurses.
Okay, welcome back everyone. I have a lot of questions. We have prepared questions and we have some questions in the chat, but I want to ask a first question. I take the opportunity to do this, and that's for Miriam. I mean, if you look at countries where perhaps resources are more scarce, or in general, if I would ask you, what would the number one recommendation be for nurses, who administer chemotherapy or hazardous drugs? Like, what would the most important measure be, in your opinion?
Well, I think that the most important thing is that you know that you have awareness. So I would suggest to areas where the healthcare budget is not so large to first start with education. That doesn't have to cost a lot. And we have this saying, forewarned is forearmed. So first of all, you have to know which drugs are hazardous. That's number one. So you know when you're handling them. You have to know by which routes you can be exposed to them, what are the most dangerous tasks, and how you can prevent spreading, because you're protecting yourself, but also your colleagues. So I would say first install training and give it to everybody in the whole cancer continuum that's surrounding chemo, because often healthcare management of hospitals, they might forget, for example, the cleaners. But a cleaning person can be someone who is spreading contamination if he is using the same mop in the chemo ward as in the next ward. So everybody has a right to have a good education. And then if you have the issue of PPEs, I think everybody has a right to have full PPE, but definitely have good gloves. I was a little bit scared by the pictures in Alison's lecture with gloves that just, because you are doing most of your tasks with your hands, therefore gloves are really important.
Okay, thank you, Miriam. That was good, and I think we could all do, and I think we shouldn't even have to question all of this, but still, it's another question that came up in the chat was regarding recommendations to patients, and this goes for all three of you, but from both your perspectives, patient that's receiving chemo at home. I'm thinking it's other people involved there. So if you want to say something on that, all of you are invited to respond.
Shall I go? I think it depends I suppose it depends what you mean by that, really. If they're having chemotherapy at home, we send patients home with pumps, for example, so they are receiving chemotherapy at home over a couple of days sometimes. We do generally try and educate those patients so that they understand what the risks are when they go home. And I know some of our trusts in the UK will actually send the patients home with a bit of a spillage kit themselves, so that they know, or at least kind of a cytotoxic waste bin. So if anything happens, they've got somewhere to put the chemotherapy in, and then they know just to kind of come straight into the unit with the bin. It's different. It's sort of to different degrees in the UK. So some trusts are very hot on it, and they send the patient home with a lot of information. And I know other trusts are perhaps not quite so good at it. So in the UK, it's quite variable. But I mean, generally, certainly from an education point of view, we will advise that patients are educated about, not just about them having chemotherapy at home, but also about their waste, because obviously once the patients have had chemotherapy and they go home, they are still putting all of their family members and friends at risk of exposure through excretion. So we do always recommend that nurses will educate patients around the risks of exposure through that as well.
And I think sorry, Helena, butting in there. I was just going to, yeah, absolutely. What Sam said is absolutely spot on. And I think it's something, I mean, Sam have talked about it. It's an area that needs a lot more research into, because I think it is an area that we are missing, is the exposure to carers as well. And as we're shifting from different places of giving chemotherapy, that risk is still there. And like Sam said, it is hit and miss, and I think it's an area that a lot more research needs to be done in, to get some more data on how big a risk is that, and actually are we educating those patients and their family adequately or not.
I fully agree, and we also educate our patients. I think there is a difference between us as workers and carers, because fortunately, most people will have a limited time on chemo, but we as workers, maybe for 40 years, for 5 days a week, we have this exposure risk. So for us, the risk is greater. And I think that with some small educational things like how to use the toilet, actually, like by closing the lid before you flush it, you prevent spreading. So that's something I think is very important to teach patients. But not, it is a difficult thing to do, because you don't want to scare the patient so much that they can no longer have a cuddle if they're having a hard time. Because if you have one big hug from your father or mother, that's not a big risk to them, because it's once. We are working every day, year after year, and then we have a cumulative effect. So it's a balance, and I agree that we need to learn more about it, because we're also sometimes struggling a little bit with how to best educate the patient who goes home.
Thank you all. And we have had quite a few people asking, like, what would the recommendations be on swipe testing, like on surfaces where we work? Like, we heard a few examples from both Harold and Maria, how it's done, and I know a little bit from where I work, but what would the recommendations be? Maybe perhaps to you, Miriam, first, but then, you know, this is, a lot of people have asked this in the chat.
There is no European guideline on how often you should do wipe sampling. So a lot of countries do it once a year, but I think you should determine the frequency based on the results. Because if you find after your first set of wipe samples, you will probably find that some spots are contaminated where you don't expect it. And then you can take measures to increase the cleaning frequency, or definitely stop using spikes in bags, because that's not, that's why we get contamination under the infusion stand, I think. And then you can change work procedures, because wipe sampling is only a way to check if you're working safely. And then you do them again to see if your intervention has had an effect. And if you come to a point where you have very low contamination, then maybe once every 2 years is enough. So I would suggest that you start and then you adjust your frequency based on the findings, because we do have guidance values in Europe. They can be found in all the guidelines.
Thank you. Does Samantha or Alison anything to add, or is it similar line of thinking?
Well, we don't do wipe testing in the UK at all. So it's something that we're very obviously keen to get sort of started with in the UK. The issue for us generally is around cost, because we have a National Health Service, and so every penny is counted into our into the health services that we provide, and so it makes it a little bit more difficult often to kind of implement things unless there is, you know, a definitive guideline to tell us that we should do it. And obviously, as Alison said in our presentation, we are no longer really governed by a lot of the European guidelines, unfortunately, which makes our job a lot harder, because, you know, we're going to have to start looking into having our own guidelines, which you know, we've really struggled with in the UK. So from a UK perspective, at least, you know, wipe testing is not something that is commonly done. It has been done in some sort of individual hospitals and areas where you know, somebody's quite keen to implement you know, a closed system, for example. They will do the wipe testing to prove that there's an issue, but it's certainly not something that's regularly done.
Yeah, it's a shame. It's almost like they don't want to look for it because they know they're going to find it and then they'll have to do something about it. It's a bit like back in the day when we had MRSA swabs, and all nurses had MRSA swabs. And funnily enough, they found MRSA. So it's kind of, from that point of view, so I think almost they're frightened to swab it in case they find something, and then they're going to have to do something about it, which is going to cost money.
Thank you. This is very interesting. I know that, Matt, you have a question too.
Yeah, it's something I actually wanted to ask Sam and Alison. It's, as we try and reduce the amount of times that cancer patients come to the hospital, what are your thoughts on cancer patients being taught how to remove their own 5FU pumps and flush their PICC line or their Hickman line, for example?
So I think it's going to, I mean, if that was something we were looking at, it would have to be very heavily risk assessed on an individual basis, that, you know, you'd have to assess the patient in terms of how capable they would be of doing that procedure themselves. Obviously, it kind of, I suppose it prevents the risk to us a little bit. Although, having said that, you know, a lot of our patients are their pumps removed by district nurses and not by the chemo units now. So it's kind of been, it's a task that's almost been taken away from chemo nurses anyway in a lot of ways, because we do get other people to do that. I personally couldn't see a problem as long as, like I say, there was a risk assessment done, that patient was, you know, sufficiently able to manage that as a procedure. I think the issue with PICC lines is more about actual ability of, because you've only got one hand to do the flushing and, you know, all that kind of the logistics of it perhaps a bit more difficult. If it's a Hickman line, I can't see why not, you know, it's probably quite doable. But obviously, like I say, it's about assessing the risk for individuals, I think, on an individual basis. And I suppose then it's about disposal, because actually what do they do with the pump then once they've put it, you know, they'd have to still bring the pump back to the hospital anyway in the bin. So it's about the sort of waste disposal as well.
Yeah, I mean, I think if it's doable, I think it's a really good idea. But like Sam says, I think it's got to be heavily assessed, and I think you know, it's going to have to be heavily sort of monitored as well, because you can't just assume just because somebody's got a 5FU pump they're going to be able to do that, or actually will want to do that for themselves, because actually sometimes it's you know, it's too much for them, and actually they do want to come into the hospital because they do want that reassurance. So very, very much you know, like Sam says, on an individual basis, but I think there could be a place for it.
Okay, thank you so much. We get a lot of questions in the chat, and I also have one, I think, you know, to you mainly, Miriam, but I because it's a question on the findings that you presented. you know, the fact that you saw that multi-way infusion systems decreased exposure, but not so much CSTDs, and just, you know, a reflection on those results. I think it would be interesting.
Yeah, I think the issue is that we always want to have a barrier between the persons administering or compounding and the chemo itself. That's the key thing. And closed system transfer devices, that's not a protected name. So people can say, I have manufactured a closed system device, and they can bring it to the market. And I think that they're not really always closed, because the testing for drugs, if you want to bring a new drug to the market, you have to do clinical trials and compare to the gold standard. And for medical devices, the legislation is not so strict. So everybody can say, I put this on the market, it's a closed system. So that's why I think it's important that we do this independent research. And maybe also some management sometimes think, oh, we have a closed system, that's easy, we just buy that and then we're done. But that's never good. It's a package of things that you have to do to protect yourself. It's a package of procedures, training, good technical work. You cannot do just one and then think you're done and then you go away. You need it all. And the multi-way infusion line is really good because it is always there and it always functions. It's not depending on technology. It just depends on the neutral fluid in between you and the chemo. So that's really, it's not that expensive actually also to do that.
It also supports the thing many people have been commenting in the chat that, you know, education is key. So like it doesn't matter if we have all the fancy equipment, we need to be educated as well in a way. So that's very, you know, and then someone have asked in the chat, this is basically, I think for all of you, your view on, you know, if you have regular gloves, like is it a difference? Should you have, you know, double gloves or not? You know, your view on that. I think it came up before, so it could be interesting to hear what you think.
Yeah, if you have chemo gloves, you can switch them according to what the leaflet says, because they get tested and they will say, okay, this one is for 1 hour, this one is for that many hours. And if you have only normal gloves, most colleagues do wear doubles. Also, the pharmacy technicians in the countries where they have no good chemo gloves, they wear double gloves, but they should be long enough, because otherwise, even if you have normal gloves, you should have them a little bit longer so that you protect your wrists, because they come into contact as well. Yeah, but maybe Sam and Alison knows all about the gloves, because those are actual pictures from your hospital, right? Yeah.
Yes, unfortunately they are, and I can't tell you the amount of times that used to happen to me, and it is incredibly worrying. So I think from my point of view, the key is to get the gloves right in the first place, so we don't have to wear double gloves. But clearly we're a long way off that. So I can understand why somebody would wear double gloves, because obviously you've seen the pictures that I put up there. My worry is about the dexterity with double gloves. I don't know if there's any research on that. You know, it's just something that it was always, I always found a problem when I was wearing two gloves, was the dexterity. That's that finer motor sort of stuff. But yeah, I think anything that's better than what we've got in the UK would be great. But Miriam, you're absolutely right. We need them right at the arm, not finishing on the cuff there. But I'm sure Sam can tell you more about how it is in practice, and if the gloves have improved at all recently. And I'm hoping she'll say they have.
No, I think that the other thing to raise is I don't think nurses are aware that they have a limited time with gloves, because they obviously the drugs can actually get through, and I think a lot of nurses don't realise that they have a set amount of time that they should be using the gloves for. And if you're sitting giving, so I know a lot of places use pumps now, so they don't necessarily, nurses don't always sit giving, like we used to sit giving, you know, a lot of vesicant drugs, you know, boluses in the UK, probably not so much in other countries, but we would sit giving, for example, epirubicin over sort of half an hour to an hour, just in syringes, and we'd literally be holding the syringe with our gloves on, with a piece of gauze under the giving set to catch the drips, for, you know, sometimes up to an hour. We generally don't do that so much anymore, but my concern then is actually you've had the same pair of gloves on for all that time, so actually there is the risk that the drugs can actually get through the gloves by that point. So in my opinion, yes, we should be double gloving, particularly if you're going to be doing any procedures where you're leaving them on for a length of time and then still handling chemotherapy drugs. Theoretically, we shouldn't be doing that because we should be changing our gloves more frequently. And actually, it's probably more about educating the nurses that you should be changing your gloves, certainly, you know, in between any sort of interactions with patients, but you shouldn't be leaving gloves on for that length of time anyway. With regards to the length, no, unfortunately, ours do stop at the wrist, and we have no arm protection in most of our trusts in the UK. So we've always got the risk of exposure by that, you know, in that part of the arm as well.
Okay, thank you for this. We have many questions. One is on, you know, nurses working in inpatient wards. You know, do you have a specific measures to deal with excretions, like for how long? And so if you have something to say on that.
Yes, that depends on the drug. Some drugs have a short half-life, and then the excreta are only contaminated for 2 days or 3 days, some up to 7 days. So your hospital should provide you with a list of all the hazardous drugs and the time frame for which you have to take measures to protect yourself from excreta. And then there are two occasions where you have to do that. One is in the regular care, if you have to help a patient to go to the toilet, and one is when a patient is vomiting, for example, then you have to have a spill kit with the necessary things to help you clean up that in a safe way for yourself and for your colleagues. So yes, you should have a list, because it really depends on the drug, how long the urine or the feces are contaminated.
So we educate our nurses actually that anything up to 7 days as a general blanket rule, because I think that's safer, because, you know, if you just treat everyone's excreta in the same way for up to 7 days, then you're, you know, it's probably the safest way to handle it. So that's certainly what we on our chemotherapy course, that's what we will teach our students, that, you know, they should manage any excreta within 7 days, because obviously, you know, I know drugs have different rates, but people have different rates of metabolism as well. So you can't necessarily guarantee, you know, that's what's metabolized by one person in 48 hours might take someone else longer. So I think as a precaution, that's generally what we would say, certainly for our nurses that do our course anyway.
Yeah, and like you said, Miriam, about, you know, the nursing care duties as well, we should be wearing gloves. And we had a rather large battle again, because we were in direct conflict with infection control, who were saying that we shouldn't be wearing gloves to make beds and things. And we were like, no, because actually we may have had a lymphoma patient who sweated half their body weight overnight and it's drenched in potential chemotherapy, and I'm not going in there without my gloves on. So yeah, I absolutely agree that it's not just about, you know, physically taking the waste away, for example, but it is all the other nursing care as well. We need to, you know, still be wearing gloves, like Sam says, up to 7 days, just as a blanket rule. So it's a bit of a catch-all, really.
Also, when you are washing a patient who is not able to go to the shower himself, and when they're in the bed and you're washing, you should wear gloves, because sweat also can contain traces of chemotherapy.
Absolutely, but again, it's all about changing your gloves as well between patients. And yes, we should be doing that, but we know that that doesn't always happen. And then you're going from washing a patient who may have excreted chemotherapy to a patient who's not been receiving chemotherapy. So yeah, absolutely, we should be wearing gloves for all those tasks, but it's all about, again, the time frame and changing them regularly, washing our hands in between and changing our gloves regularly. It's all about education. But I would say that, wouldn't I?
Yeah, no, but I think it's a whole process of things. That's what we've been reflecting within EONS, that, you know, it's the whole process of from start to finish. But we have got a few questions on, you know, making a difference. Like we speak about hazardous drugs or cytotoxic drugs or chemotherapy, but like, would your recommendations vary if you give immunotherapy, for example, or something else, or would you recommend the same?
No, I would not recommend the same, because the most hazardous drugs are the drugs that directly interact with your DNA. So those are the classical cytotoxic drugs. Immunotherapy and targeted therapy are very large protein molecules. So the first thing is they cannot just be absorbed through your skin, because proteins don't do that. That's why we always have to inject insulin, and it cannot inhale or ingest it. So it's really, first, there's a barrier, a natural barrier in your body that protects you. And second of all, they don't interact with your DNA, so they are not carcinogenic or mutagenic by nature. Having said that, we now get all these new drugs that are conjugates between an antibody and a cytotoxic drug. So I say brentuximab vedotin, trastuzumab emtansine, things like that. I would consider those hazardous. And if you doubt, always better take the full PPE. If you're in doubt, better be safe than sorry, right?
Absolutely.
No, and I want Sam and Alison to say something too, because as a nurse, I take on what you said the last. You know, I can't really differ going into a patient having one thing.
Yeah, absolutely.
But please, let's say
Sorry,
something,
yeah.
Sam and Alison.
We're probably going to a little disagree with our pharmacists.
Yeah, but that's fine. That's not what we should do here.
The thing for us, and I know Sam's going to say it as well, is that we haven't been using these drugs long enough to know what the long-term effects are. And that goes for monoclonal antibodies as well. And, you know, we've seen it with antibiotics, you know, and we've spoken to many nurses who, you know, are now resistant to antibiotics and things like that because of accidental exposure and things like that. So for me, you know, if it's an unknown risk, we should be wearing full PPE to protect us. That's my personal opinion, and I know, you know, not everybody will agree with that. But, you know, you wouldn't be expected. I mean, look at COVID, it's an unknown risk to a degree, and yet we're fully PPE'd up. So, you know, you wouldn't be expected for somebody to go and handle something that we don't know the risk of without any protection. But I know Sam's going to say that as well.
Well, yeah, and I have to say, again, apologies to, I've heard conflicting views from another pharmacist about the whole issue of the size of the molecules and that actually we can absorb them. And so that's my concern, is I've heard lots of different kind of views about this. And I know a lot of people have said about the molecules and etc. But again, it's an unknown risk. You know, and with us dealing with them, the problem is now there's been such a boom, particularly in immunotherapy, certainly in the UK. It's probably happening all over the place, but, you know, we've seen such a massive increase in usage of immunotherapies. My concern is, you know, we don't know what that's going to do to our immune systems in the longer term. You know, we do have exposure to those drugs, whether it be, you know, we're not absorbing it through the skin, whatever, you know, whatever way. I have heard arguments to say that we do absorb them through the skin. So, you know, if we don't know 110% certain that these are safe, we should still be treating them as hazardous, in my opinion. That, you know, the risk of exposure is still high, and we don't know, like Alice said, the longer term effects, particularly with the immunotherapies. You know, they are really quite new, and we don't know the effects that they might have when we're all older and grayer, I should say.
Yeah, I can just say that we've been what we are discussing now is important to bring up, and I think it's different ways to look at it, but we cannot sort of have different routines going into. So the precautionary rule here really is you know, overriding everything here. So I think despite our views, that's a good thing to think about. But we also had questions quite a lot from more than one person asking, you know, should we have regular testing for healthcare professionals such as nurses you know, like blood tests or urine tests or something to see if we're exposed, or what is your take on this?
So this has been a question that's been knocking around for a very long time, that Alison and I have kind of tried to answer, I suppose. The straight answer really is no, not necessarily, purely because, you know, we can't link 100% that if your blood test's affected, we can't say 100% that's because you've been exposed to chemotherapy. There are a million reasons why your white cell count might be a bit high or a bit low. You know, there are so many reasons. It's like even with looking at drugs in urine, for example, with platinums, we know there's loads of platinums all in the environment around us. So actually it's a pointless exercise to monitor certain levels of drugs in the urine, because also we know, yes, you may have been exposed to that drug, but we don't know if it's done you any damage. So, you know, this is the whole issue with all of the safety elements of sort of, particularly with cytotoxic drugs. There's so little evidence around the actual damage that's done and the link between, you know, because we're working with the drugs, that they are affecting us, and sort of doing things like blood testing. My own trust, quite a few years ago, my hospital started testing our chemotherapy nurses for blood. They did full blood counts and electrolyte testing, and they basically just found out that it opened a massive can of worms that they didn't know how to deal with, because obviously lots of staff came back with abnormal results, and then obviously all of those had to be dealt with. They had to be monitored every 3 months, with no clear answers, you know, of kind of like, well, we know because you've got this blood count, this is what's going to happen. So, you know, it's a really difficult thing. I'm not saying there should be no monitoring, because I think it's fine if you do have monitoring. You've got to understand how to deal with it. You know, don't just start doing it because we know staff get exposure. Don't just start testing for the sake of testing. You've got to kind of understand what it is you're testing, what you're looking for, and then how you're going to deal with the fallout of that afterwards.
I agree with Samantha, because I've seen studies where they check mutagenic ratio in the urine, but that is a very indistinctive test. So if you happen to live next to a highway and you're on your balcony in the evening enjoying yourself and you're inhaling the fumes from the traffic, you will have a very high level, but then you cannot distinguish that from exposure at work. So it's very difficult, if you want to implement that, how you will interpret it. So I think as yet the science is not far enough.
And I guess I like you said, all of you, this question have popped up also in other, you know, but like if you would advise someone that wants to improve safety where they work, you know, like, do you have any general advice what you could start with, or you know, how to both deal with potential risks in your workplace, or you know, what would your main advice would be?
I mean, I don't think that the biological testing on its own would be sufficient. No. I think it needs to be used alongside other measures. So maybe the wipe testing, it might be something sort of, you know, chatting to other members of staff, you know, a bit like what we did in our survey, and just asking if they'd experienced any sort of adverse events when they were, you know, administering chemo. Because actually what we found is, until we started talking about it and opening that dialogue and having that conversation about it, certainly we noticed this in our lectures, is that when we started talking about it, you could see light bulbs going on and people going, I always have a headache, or, you know, my skin's been very itchy and things like that. And you could see that actually people were making the connection of what they were experiencing to actually potentially the exposure. So I think it's about having those conversations with, you know, their wider team, to start getting that on the radar, and then looking at exploring other things like the wipe testing, maybe biological testing, but not alone. It's got to be as a collective.
Yeah, the other thing you can do, so my occupational health department in my trust actually do questionnaires every 3 years. So, and that's probably more effective, I think, than certainly than any of the sort of blood monitoring. So just a simple questionnaire about things like, you know, have you had any skin rashes, any problems with you know, regular headaches, or, you know, it's that kind of general health questionnaire, I guess, to see if the situation changes. So because obviously a lot of our nurses, like Miriam said before, we, you know, we could be giving chemo for 30 or 40 years. So, you know, it's important to have those regular contact points just to say, you know, yes, this has changed from 3 years ago. You know, I'm having more skin problems, or, you know, I'm having these additional health problems, as a record then that, you know. And the other issue then is actually keeping a record of people who give chemotherapy, because, you know, if you need that regular sort of checks on your health to be able to identify any changes. So it's important that we know who's giving chemotherapy in the trust at any one time as well.
And there might be like clusters of people, and we've seen this, haven't we, Sam? In some trusts, there's been clusters of similar sort of adverse reactions, and actually it might have been that there was, you know, a dodgy batch of chemotherapy or a dodgy batch of giving sets that were, you know, that they were using and things like that. So it's looking for clusters and suppose patterns in that data as well.
And I like what you said about occupational health department. We also have occupational hygienists. And I think that they should go and audit the places where we work with chemo and look at the whole pathway of the chemo. So from coming into the hospital, preparing it, administrating it, caring for the patients, the laundry room. And then, you know, we get all these audits. I know some of you are working in hemato-oncology. You get the JC accreditation, and we get all these audits about patient safety. We should also be allowed to have audits of worker safety, because, you know, we are the ones who are caring for the patients, everybody doing that, but we also have a right to have an audit for how safe we are working. So that's, I think, what would be something to strive for.
No, I couldn't agree more with all of you, and I think we should. I mean, I can see from, and I want to apologize that we won't have time for all the questions in the chat. We had a lot of questions, and I also can see that people are connecting, like saying, you can email me, I have tips for that, this and that, and that's great. That's also what we want. And you could always get in touch with us after, like if it's anything, us that are arranging this. And then also remember that this will be available on YouTube, you know, so people can watch this again. And then also we had a lot of sort of comments asking like, how is the European situation, and a little bit of data of that we do have in EONS. You could also look in our website, you know, for that. And I think Miriam's last comment to, you know, be more strict and have audits and see this as a big and important thing for our health and safety in general is very important. And also what we're doing today, work together and talk together about things, different professionals. I think it's so important. So I'm not sure, does anyone in the panel or Matt or have anything more you want to add? We still have some time. Otherwise, I think we will close the chat anyway for questions.
I think if I can just add one thing, there's a couple of things. The message that keeps coming through for me is, and I don't wish to sound like a politician, but it's education, education, education seems to me to be the key thing here. And I think us as a community of healthcare professionals, we've got a duty of care to make sure that we're actually looking out for each other and making sure that we are trying to protect each other as well here. I'd like to pick up on something Miriam just said with regards to looking at, you know, the stringent measures with regards to JC. This is something that within EONS we're actually looking at the moment. We're working within our advocacy group to look at an accreditation system. And it's very much, it's work in progress. We've just started up a small working group, but we really feel strongly that in order to have, you know, safe working environments, as well as safe environments for patients, because for me, safety for the healthcare professional and the patient goes hand in hand. We're looking at working on that as well. So watch this space. That's definitely something that's that we're working on, and we'll be expanding upon quite soon.
Yes, okay. I think it's time to wrap things up, and I want to thank everyone so much and the over 100 participants. And please don't hang up yet. We have some take-home messages from us in EONS, but I just want to thank everyone so much for being so active also.
I just want to echo everything that my friend Helena has just said. Thank you all to the panel and to everybody for coming along today. And don't forget, at the end of this webinar, we're going to be releasing the next safety webinar, which will be, we're actually looking at safety culture and speaking up. And we're very lucky to have Professor Schwapach and also Dr. Oldenmenger, who's she's on our EONS board. And luckily, that'll be myself and Helena again that are going to be co-chairing this event. So please register, and we look forward to seeing you there.